And then at the end of the lecture, you may ask me questions. Can everyone hear?
Yes, sir.
Okay, so let's start then, all right? Okay, can you see the lecture?
Yes, sir, we can see.
Okay, right. So salivary gland disorders are not very common. Okay, so you may not see them as commonly as you would see many other gastrointestinal diseases, but in certain populations, you can see them commonly. Okay, so to begin with, let's try and recapitulate the basic anatomy of salivary glands, which you have been taught in the first 2 years. So nothing major. You know there are two types of salivary glands. There are the major salivary glands and the minor salivary glands. The major salivary glands, there are 3 pairs. So altogether there are 6 salivary glands, 3 on the left side and 3 on the right side. And you know that they are, you can look at this diagram, the 3 major salivary glands on each side are the parotid gland, the submandibular gland, and the sublingual gland. So there are 3 pairs, altogether 6 major glands. So similarly, there are minor salivary glands, but the thing with the minor salivary glands is that there are so many. So actually there are about 1,000, close to about 1,000 minor salivary glands in the human body. And they are mostly located in the upper digestive system or aerodigestive tract, predominantly within the oral cavity. So in the lips, in the cheeks, palate, floor of the mouth, that is where you see the minor salivary glands. And they might go up to about 1,000 in number. Okay. So this diagram shows predominantly the arrangement of the major salivary glands in the body, the parotid with the parotid duct, submandibular and the submandibular duct, and the sublingual gland with multiple ducts. Right, so the next step of the lecture is to decide on a classification system to describe the various disorders you see in the salivary glands. So if you classify those diseases into a common known framework, you can see that there are developmental disorders. There are functional disorders in the salivary gland. There are cysts occurring in the salivary glands. Diseases due to obstruction of the salivary glands. So there are obstructive disorders. Similarly, there are inflammatory conditions occurring in the salivary glands, degenerative problems, and neoplastic conditions. These neoplastic conditions of salivary glands can be benign and malignant, just like in any other neoplasm. Okay. Right, so let's start by talking about the developmental disorders. That's the first category of salivary gland diseases. So, unlike in many organs, congenital problems of salivary glands are very rare. Now, if you look at, say, for instance, pancreas, you have things like annular pancreas, pancreas divisum, etc. Right? So they are developmental abnormalities. Or if you take something like the duodenum, you still have duodenal atresia, right? Which is not uncommon. But compared to those, developmental problems in the salivary glands are quite rare. So agenesis, atresia, congenital fistulas, they are very rare in salivary glands. What you might see, if at all, is something called Stephane's bone cysts, which is a congenital problem. That happens because salivary gland tissues are, when salivary gland tissues are implanted at ectopic sites. For instance, in this case, in the jaw or the mandible, right? If you take an X-ray for some other reason, now in this photograph, the X-ray was not taken to detect the bone cyst, but it was detected obviously for some dental reason. And incidentally, they have detected this radiolucent area on the left side of the mandible, which is a bone cyst, Stephanie bone cyst, that occurs due to ectopic implantation of salivary gland tissues. So apart from that condition, every other developmental abnormality is quite rare in salivary glands. Okay, so let's go to the next category of problems. Functional problems. Okay, functional disorders of salivary glands, meaning that there is no real structural abnormality, but functionally the salivary gland is impaired. So the main function of the salivary gland, as you know, is to produce saliva. So there could be functional problems that can cause in increasing in salivary production. That condition is called sialuria, right? So there is overproduction and flow of saliva. Similarly, there are conditions which can cause a reduction in the salivary gland salivary production. That's called xerostomia. In some conditions, salivary production is almost zero, right? So for sialuria, for increased production, things like mental retardation, certain neurological problems, rabies, you get this increased production in saliva. For the other extreme, where you have less saliva production, certain conditions like mumps, which is an inflammatory condition, sarcoidosis, which is a connective tissue problem, right? And radiation-induced changes in the salivary glands, they can cause a reduction in the saliva production and flow. Okay? So those are the different types of functional diseases that you see in the salivary glands. That's the second category. Now let's look at a more interesting category which you might see, especially when you start doing surgical appointments, internship in surgery, pediatric surgery, right? So if you happen to work in maybe ENT related fields or dental institutes, you will see this condition very commonly, right? These are cysts associated with salivary glands, right? So as you know, a cyst is a fluid-filled cavity which is lined by epithelium. So a fluid-filled structure lined by epithelium is called a cyst. So in relation to salivary glands, which are major as well as minor salivary glands, there are two types of cysts. One type of cyst is called the extravasation cyst. The other type is called a retention cyst. That classification may not be very important, but just know there are cysts occurring in relation to salivary glands. One of the most commonly seen cysts in clinical practice, salivary gland cyst, is something called a mucus retention cyst. Mucoceles, they are called, right? I mean, if you think of yourself, even some of you would have had a mucocele at some point of your life. Certainly when you have damaged teeth, dental caries, if you are wearing dentures, right? With constant friction of the upper or lower lip, it's not uncommon to get a mucocele or a mucus retention cyst. As I told you in the very first slide, there are thousands of minor salivary glands in the lips, in a flow of mouth, that area. So for some reason, if you get repeated trauma to the mucosa in the lower lip, for instance, that might damage or destroy few of these minor salivary glands. And that might lead to obstruction of these very, very microscopic small salivary glands, which will lead to accumulation of the mucus or the saliva within this cyst, right? And for after a few weeks, it is presented as a mucus retention cyst or a mucocele. Okay, that's a very commonly seen clinical condition. The next condition that I'm going to talk to you again is a cyst, but it's less common. It's called a ranula. Again, when you start doing general surgery or ENT, you might see this condition often. It's called a ranula. So there, the cyst occurs in the floor of the mouth in relation to the sublingual gland. If you can remember, I told you the sublingual glands are a pair of major salivary glands, which is located in the floor of the mouth. So there, the saliva or the secretions are accumulated in relation to the sublingual gland. The ranula is usually quite large compared to a very small mucus retention cyst of the lip, right? Sometimes it occupies the entire floor of the mouth. So there are different types of ranulas. Some ranulas are exclusively or only situated in the floor of the mouth, right? Certain ranulas, certain cysts extend partly inside the mouth, in the floor of the mouth, and a part of it extends into the neck. So it's like a dumbbell, like an hourglass shape. Half of it is inside the mouth, half of it is in the neck, in the submandibular space, right? So that kind of a ranula is called a plunging ranula. Okay, that's a clinical diagnosis. So whatever these conditions are, whether it's a mucus retention cyst or a ranula or a plunging ranula, the diagnosis is a clinical diagnosis. There is no test, no scan to say this is a ranula, okay, or a mucus cyst. If you can remember these two photographs, whenever you see a patient like this, it will come to your mind, right? Management. So I told you the pathophysiology or the mechanism of this cyst. These ducts are blocked due to trauma or some reason. So secretions are accumulated. So what you have to do is to excise this cyst or remove this cyst, and also the affected salivary gland. So if it is a ranula, you remove the cyst and also the affected sublingual gland. If it is a mucus retention cyst, when you remove that cyst, along with it, you remove the mucosa of the lip in that area. So that will invariably remove the affected minor salivary glands. So that's the treatment for cysts. Okay, so that is the third category: developmental anomalies, functional anomalies, and cysts. Then we move on to a more important area of salivary gland problems, which is an obstructive disorder. Now, obstructive disorders of salivary glands occur. Now, I told you each salivary glands, major as well as minor, they have a duct. So obstructive disorders mostly occur in relation to the major salivary glands. And for some reason, their salivary flow through the duct is obstructed. Now, if you remember this photo, you can see the ducts. Parotid has a nice big duct going along the masseter. Then your submandibular gland has a nice duct which curves upwards, which opens into the flow of the mouth, right? So similarly, if those ducts get obstructed, the secretions, the saliva that is produced in that gland can't come out. Okay, so that happens usually due to a stone or a stricture or some kind of obstruction at the opening of the duct. Now, for instance, if you have malfitting dentures, right? Your old grandparents might wear dentures. And if those dentures are malfitting, they might come and block where the salivary gland duct is opening inside the mouth. So when that happens, the duct opening gets blocked, right? So that duct opening is called the papilla, that will get obstructed, okay? Or the commonest reason is sialolithiasis. Sialolithiasis is stones in the salivary glands. And these, when you talk about these stones, the commonest gland to form stones is the submandibular gland, not the parotid gland. Parotid gland is the biggest one, but stones occur most commonly in the submandibular gland. About 80% of stones occur there. Only 20% stones occur in the parotid gland. So now this is a question to the audience. Can you tell me at least two reasons why stones are commoner in the submandibular gland compared to the parotid gland? Give me two reasons why it happens.
Its secretions are thick than the parotid and pathways longer than.
Yes, good. So when you talk about, when you look at secretions, the type of secretions that come out from the parotid gland is predominantly serous. It's like very water. Submandibular secretions are somewhat serous and mostly mucus. It's thicker, right? And the other thing is, yes, the duct is longer in the submandibular gland. Not only it's longer, the course is upwards, right? Submandibular gland lies below and the opening is above. It's in the floor of the mouth. So the secretions have to actually travel against gravity compared to the parotid gland where the duct is almost straight. Okay. So the secretions of the submandibular gland find it a little bit difficult to open. They are thicker and the duct courses upwards. Okay. Because of that, there is more chance for the ducts to get blocked with very thick secretions, which will ultimately form stones. Okay. So those are the reasons for obstructive disorders of the salivary gland. So sialolithiasis is the commonest stones. So if you talk a little bit more about sialolithiasis, as you can work out, when you have a stone in a major salivary gland, the submandibular, for example, what happens when you eat is, with meals, you know that there is secretion of saliva, right? In between meals, it's minimum, but when you start eating, the saliva secretes. But what happens when the duct is blocked by a stone or stricture? The saliva that is produced with meals can't come out. Therefore, there is a sudden production, but it can't come out of it. Therefore, the gland is enlarged with this newly produced saliva and it causes severe pain. So characteristically, those who have obstruction or obstructive disorders or sialolithiasis, they have sudden pain and also enlargement of the affected salivary gland. Then that happens with meals. Okay. And then slowly after a few hours, the swelling and the pain subsides because the gland reabsorbs the saliva. Okay. So that is a classic history. So how do you diagnose this? So this X-ray is called, this is a very special type of X-ray. So if you just take a normal X-ray of the face, you can't see these stones. This view is called intraoral occlusal view. So if you suspect a submandibular gland or a duct stone, you have to specifically write as intraoral occlusal view, right? If not, the radiographer will just take a face X-ray and that won't show anything. If you take an intraoral occlusal view, most of the submandibular stones can be seen just like this one. Okay, and here you can see there is a very big stone quite close to the opening of the submandibular gland at the floor of the mouth. So X-ray is one way. In the olden days, or previously, we used to do something called a sialogram. So just like esophagogram, fistulogram, right? You understand when you say sialogram, it is a contrast study, right? So how do you do the contrast study? Is you inject the contrast through the opening of the duct. So if it is the submandibular gland in the floor of the mouth, you know there are two openings on either side of the frenulum of the tongue. So you put a small cannula into the opening and inject contrast. Then it will visualize the pathway along the duct. So that is called a sialogram. But the problem is sialograms can be risky, especially when you have an acute obstruction, acute inflammation, right? Because if the stone is blocked and if there is bacterial infection within the gland, by injecting contrast under pressure, you're making the infection worse. So the infection, which is localized to the gland, might now get into the bloodstream. So sialograms are not very commonly done nowadays. Okay. Right. So how do you manage this condition, obstructive condition? Obviously, if the patient has pain, you manage the pain. So symptomatic management. Depending on where the stone is, you can remove the stone, just the stone. Or sometimes if the stone is very, very embedded within the gland itself, you might have to remove the entire salivary gland. That's called sialadinectomy. Now, for instance, submandibular stones are mostly within the duct. So if you know where the stone is, you can just open into the duct, make a small cut there, remove the stone. But some of the parotid stones are right inside the gland. They are stuck inside the gland. Therefore, just opening the duct will not be helpful. You might have to remove the entire gland. So sialadinectomy will be necessary in some cases. Okay, so we have covered an interesting and important area of disorders, which was the obstructive disorders. So the three common reasons for obstructive disorders are stones, strictures, and obstruction of the papilla due to various trauma or ill-fitting dentures or things like that. So if you have an obstruction, it will cause pain and enlargement of the gland during meals, right? And you can do certain investigations to locate the stone or the block, and then the treatment will be dependent on that. Right, so the next category of disorders are called inflammatory disorders. Inflammation of the salivary glands, Sialadenitis. Okay. So obviously, if you have an obstruction due to stone, it might also lead to Sialadenitis. But apart from that, there are many other reasons. So these inflammatory disorders are mostly because of infections, right? And rarely because of just non-infective inflammatory disorders like sarcoidosis. Most of you would have seen infective disorders of the salivary glands. They are either due to bacteria or viruses. Bacterial disorders are commoner, viral disorders are rare. But we all know about mumps. Mumps is a viral disorder caused by paramyxoviruses, which affects the parotid gland mostly, sometimes the submandibular gland. So viral disease, right? But however, bacterial conditions of the salivary glands are much commoner. And they usually occur when there is some kind of obstruction, just like what we saw before, a stone, a stricture, or a obstructed papilla. So that is called bacterial sialadenitis. So if you have a viral problem, you call it viral sialadenitis. Okay. So bacterial causes, the secondary bacterial infection is usually something like Staphylococcus aureus. And the hallmark is they get repeated, sometimes repeated infections, which can even lead to a chronic bacterial infection. Some patients have parotid or submandibular infection or inflammation going on for weeks, months, years, so chronic. So in this kind of a setup, especially in countries like Sri Lanka, India, you have to consider infections like tuberculosis. Okay, so bacterial infections are common, mostly due to Staphylococcus aureus. They cause acute sialadenitis, very painful, right? Tender glands, red erythematous. Patients are very sick usually, but some patients get chronic bacterial infections. If you have things like that, consider TB. Okay, so that's the take-home message there. So let's look at a picture of a patient with sialadenitis. Now you can see the inside of the cheek, right? This, and you can see a drop of pus coming in the cheek. This is where the parotid gland opens into, just opposite the second premolar. So this opening of the parotid gland is seen. You can see a significant amount of pus. So that means there is a lot of pus formed inside the gland and inside the duct. So this is what you see in bacterial sialadenitis. Right, so how do you manage a person or a patient with sialadenitis, inflammation of the salivary glands? Obviously, symptomatic management. So if they're in pain, give adequate analgesic. Most of them have dehydration because you can't eat and drink with this painful condition. You might have to hydrate them well, especially intravenous fluids. If you see a drop of pus like this, you can take the swab for culture. You have to start them on suitable antibiotics, right? If they are very ill, you might have to start them on intravenous antibiotics. If it is a viral sialadenitis like mumps, you don't have to do anything much because it resolves spontaneously or it's self-limiting. Okay. Next, we move on to the last category of disorders of salivary glands. So now again, recapitulating, first you learned about developmental disorders. I told you it's very rare. Then you saw the functional problems, increasing secretion, reduction in secretion. Thirdly, you saw different types of cysts. I said it's quite common and it's important in the clinical practice to know this. So cysts occurring in the salivary glands. Then you saw obstructive problems in the salivary glands. And the last category you saw was inflammatory problems, either due to infective causes like bacteria or viruses, or due to non-infective causes like sarcoidosis. So either way, sialadenitis is a very important medical problem for you to know how to manage. The next category is tumors. Before we go to tumors, there is one more area that I would like to tell you. So if you look at this chart, we have covered most of it, right? So there are patients or people in the general population where their salivary glands, mostly the parotid gland, is enlarged. There is no redness, tenderness, it's just slightly enlarged. There is no obvious infective cause, inflammatory cause, tumor, right? And that's called sialadenosis. Okay. And in medical wards, you commonly see this. Can you tell me a group of people who have sialadenosis or enlargement of the salivary glands for no reason? In your physical examination, you mentioned this. What category of patients have enlarged mostly parotid glands?
Alcoholic.
Yes, there are three categories of patients. The commonest would be heavy alcoholics or alcohol consumers. The second category of patients are chronic diabetes patients, right? And the third category are patients with severe malnutrition. You might not see that category very often in Sri Lanka, but obviously maybe in countries like India, or if you have underlying problems, chronic malnutrition also leads to enlargement of parotid glands without an obvious infection or tumor. Okay, so that is Sialadenitis for you. The last category is tumors or neoplasms in the salivary glands. Okay. So I told you there are two types of neoplasms, benign neoplasms or benign tumors and malignant tumors. Of the salivary gland tumors, the majority, right, I'm talking about overall salivary gland tumors, the majority are benign. Only a few are malignant. Okay. Parotid gland is the gland which has the most number of tumors. A small percentage occurs in submandibular and also in the minor salivary glands. Now, there is hardly any difference between the histology of major and minor gland tumors. You have benign malignant ones in major and you have benign malignant ones in the minor glands also. And if you look at their histological types, they are also the same. But the only difference in minor salivary gland tumors are the majority of minor salivary gland tumors are malignant. Whereas in the major salivary glands, it's mostly benign, right? But overall, most of the salivary gland tumors are benign. Okay. So there are three types of major glands: parotid, submandibular, and sublingual. Of the three, sublingual gland tumors are very rare. But if they occur, just like the minor tumors, they are also mostly malignant. That is what you need to understand about the benign malignant nature. Now, for instance, if you see a patient with a lesion in the palate, okay, hard palate, you know there are a lot of minor salivary glands in that area. Hard palate, soft palate, cheek, lip, that is where you have the minor salivary glands. So this lesion in the palate could be a tumor arising from the minor salivary gland. And I told you that most tumors of the minor salivary are malignant. So you have a fair chance that this lesion that you see in the palate is a malignant tumor. Versus if you see a large in parotid tumor or enlargement, 80% of the time this is a benign one. Okay. Right, so let's talk about the benign diseases. Histologically, the commonest benign tumor of salivary is something called a pleomorphic adenoma. They are the commonest tumors and commonest benign tumors of salivary glands. They are very slowly growing, painless, and usually only on one side. Commonly in the parotid, sometimes you get it in the submandibular gland as well. Then there's another special type of benign tumors called the Warthin's tumor. It's called cystic adenolymphoma. That's the histological description. So that Warthin tumor is characteristically bilateral. You see it in both sides or most of the time. Only in parotids, usually in older males, right? So if you see a male in their, say, 60s or 70s with bilateral parotid enlargement and scans show a tumor, not just uniform parotid enlargement, it's very likely that this is a Warthin tumor. Okay. So they are all benign tumors of the salivary gland. Let's move to the more severe ones, the more aggressive, sinister ones, which are the malignant tumors. So what you need to know about malignant tumors of salivary glands are they are locally aggressive, right? What I mean by locally aggressive is, so in the area where the tumor is situated, they try to invade the adjacent structures. So if there are blood vessels, they erode the blood vessels, nerves, they erode. If it is close to the skull bone, the bones will be eroded. So it's different to your colorectal cancers having distant metastasis. So sometimes you get a patient with a very, early stage colonic cancer, but with already liver metastasis. So that's distant metastasis. These tumors have mostly local infiltration, right? So they just erode the adjacent structures rather than distantly metastasizing. Okay. So therefore, because they are situated in the angle of the mandible face, that area, skull base, they can easily spread into the skull base, brain, etc. Okay. So this factor I told you before, 90% of tumors in the minor glands are malignant, and most of the tumors in the major salivary glands are benign. Right, so how do you diagnose a tumor or a salivary gland neoplasm? So obviously there is a swelling which is usually painless, but how do you differentiate a malignant one if there is rapid enlargement? In the case of a parotid tumor, if there is facial nerve palsy, and if the overlying skin is involved with inflammation, ulceration, or if there is associated cervical lymph node enlargement, you can suspect a malignancy, right? So you can't just diagnose a malignancy clinically, then you have to go for imaging. So imaging of choice is something like CT scan or MRI scan. Ultrasound is useful initially, but obviously you will need further imaging with CT or MRI. So you suspect it clinically, then you do imaging. Then the next step, of course, is to get a histological diagnosis. Histological diagnosis is usually by FNAC, fine needle aspiration cytology, which is quite helpful. If you can't get a diagnosis, then you can do a true cut biopsy with a true cut needle. Bigger biopsies with an incision or open biopsies, they say contraindicated, because if you put a small incision and try to take a piece of the tumor, then you will, what they say is, you might spread it everywhere in the tract, on the skin. So then what happens is a tumor which is low grade or tumor which is early stage, you are going to spread it further, which involves the skin. Then, say for instance, a T1 tumor might become a T3 or a T4 tumor. Okay. Therefore, open biopsy techniques are usually not recommended for salivary glands. Usually recommended is an FNAC or a true cut. So that's how you diagnose: clinical, imaging, and histology. Just a quick question. I mean, you can see a massive enlargement of the left parotid gland in this elderly gentleman, and you can also appreciate the very obvious facial nerve involvement on the left side. So just by going that, you know that this is a very likely malignant tumor of the left parotid, because I told you recent rapid enlargement, facial nerve involvement, lymph node enlargement, those are all features of malignant disease. So how do you manage if you have a patient with a salivary gland tumor? Salivary gland tumor management is quite complicated, and it's not, you don't, as medical students, undergraduates, you don't need to know much details like you do for breast cancer or colorectal cancer, right? all you need to know is surgery is an important uh, step in the management. Benign tumor like pleomorphic adenoma, you remove the tumor with a rim or a margin of the normal salivary gland, right? So if it is in the submandibular gland, you remove the submandibular gland. It's called submandibular sialadenitis. But the problem is if it is in the parotid gland, you know the parotid gland has two parts, the superficial part and the deep part, so the superficial lobe and the deep lobe. Problem again with the parotid is there is a facial nerve which goes in between the superficial and the deep part, but there is no such thing in the submandibular, and therefore you can safely remove the entire gland. Therefore, in the parotid, if you have a benign tumor, we only remove the superficial part. It's called superficial parotidectomy. That we do that to preserve or to save the facial nerve. But it's different if you have a malignant parotid tumor. You might have to remove the entire gland, the superficial gland, the deep gland, which involves sometimes sacrificing the parotid nerve also, the facial nerve also. Okay, so that is radical treatment. So that's what you need to understand, and that's pretty much everything I am hoping to discuss with you about parotid glands, salivary glands. Okay, so if we were to go to this diagram again, this will tell you everything you need to know. Okay, developmental problems rare, functional problems causing increased secretion, decreased secretion. Cysts are common, mucus retention cyst or mucocele, and a ranula. Those are the two types of cysts that you need to know. Obstructive disorders, again, not uncommon, mostly due to stones, can be due to strictures. So if it is the stone, you know why it's commoner in the submandibular gland rather than the parotid gland. Inflammatory problems can be due to infections like viruses or bacteria, or non-infective causes like sarcoidosis. Whatever it is, the result is a condition called Sialadenitis, which is a very painful uh, condition that can make you very sick. So you need to know the basic management of a patient with Sialadenitis. Investigations is important to identify a possible obstruction due to stones, and I showed you certain X-rays. Investigation called Sialogram was done very commonly uh, 10, 15, 20 years ago. Now it's done less commonly. I am not saying it's not done now. It's done less commonly. If you're doing a sialogram, you have to make sure that there is no active infection going on. Because if you do a sialogram with sialadenitis going on, you are going to sometimes might even kill the patient. Okay, so wait until the acute infection is over by weeks or months, and then do a sialogram if you want to. Right? Then we came across a condition called sialadenosis, which is commonly seen in diabetes, chronic alcoholics, and malnourished people, where there is no infection, inflammation, or obstruction or tumor, but the glands are enlarged. Self-limiting condition, nothing to do. Neoplasms are very important. They are rare. Salivary neoplasms are rare. They can be benign, they can be malignant. Major salivary glands have more benign tumors. Minor salivary glands have more malignant tumors. Then if it is benign or malignant, you need to diagnose it. You take a clinical history examination, do relevant imaging tests like CT, MRI, and you rely on histology also, FNAC or true-cut biopsy. Bigger incisional biopsies are not recommended. So when you know whether it's a benign or malignant, then you can think of the treatment. So obviously you're not going to do the treatment. You will refer the patient to a cancer specialist for further opinion. Okay. So that's everything that you need to know about salivary gland diseases. Any questions? Are there any questions? Right, so if there are no questions, I will, we can stop the lecture today. Okay, right, so thank you for participating. If there's anything unclear, you can just email me.